Hi, everyone, and welcome to my section of this talk, this Shark Tank style talk. I want to thank Mike and Deidre prior to me for fantastic sessions. I'm sorry I can't be there with you. I'm here in the Great White North, in fact. I'm just pleased to be able to present a little bit today about what Mike and I with Physio U and the app have been doing to try and improve the uptake and use of outcome measures. So I'm going to run through a few slides. I've got a few demonstrations for you, and I'm sure that the rest of the session is going to be fantastic. At the end, I've got all my contact information. If anyone should have any questions or want to connect with me, please by all means do so. So I'm going to try and make the case for patient-reported outcomes and their use through mobile technologies. Now, I've called this augmented rehabilitation. I actually think that augmented rehab is probably something that is coming down the pipe, pushed forward by people like Mike and the Physio U group and the others who are talking today. First of all, I need to just disclose that I do own a small continuing professional development business, so every now and then I go and do a weekend of teaching, mostly on pain assessment, which is what I'm going to be talking about today. However, all the research that I'll be presenting today has all been funded through public arm's length providers here in Canada. No private funders on this one. So I've got sort of two broad things I want to talk about today. The first one is just describing how choosing, scoring, and interpreting good quality patient-reported outcomes properly is actually fairly hard. But on the plus side, I want to describe the reason why maybe we don't need to continue to clog your valuable mind space trying to remember cut scores and clinically important differences and reliability and validity estimates. So the first comment I want to make is that good quality patient-reported outcomes are hard. And what I mean by that is that they're not simply a function of just summing up some scores on a form, writing that score on a chart, and leaving it until the next time you do it. There's a lot more to it than that. So if we look at the history of measurement, we can go way back to the 1800s when people thought it's probably wise to start measuring things about health and wellness, in particular around population or community level health. And so they started with things that were fairly concrete to observe, things like death rates and birth rates and income and that kind of thing, unemployment. These things were all fairly concrete. We could see them. No one was going to argue whether or not that person was dead, usually. However, as time went on, I think people realized that there's more to population-level health, and certainly more to individual health, than just whether or not you're alive or dead. And so we started trying to measure more nuanced, sort of invisible things, unquantifiable things, things like pain, things like happiness, well-being, satisfaction, quality of life, these sorts of things. These are all invisible experiences. I can't crack open your skull and take a look at the neurons firing in your brain to determine how much pain you're experiencing. Really, the only way to do that is to ask you. And this has really become recognized as the gold standard for pain measurement. That is that there's really only one person who's even remotely positioned at the critical point of view and who can give us the view from in here when it comes to asking how much pain, how happy, how sad you are, and that's you, that's the patient. And so as a result, the gold standard for understanding pain really has become the patient's self-report. Now, this has required some considerable scientific development in order to do so. We've started to now break different measurement tools into different purposes. So it's no longer simply a 0 to 10 scale of pain intensity, though that continues to be a very popular measure. But now we've got tools that are intended to discriminate between people who do have a condition and don't have a condition. So they might be used for diagnosis or screening, such as a depression screen, for example. We've got tools specifically designed to predict the future, so prognostic tools. We've got tools designed to measure change over time in response to a treatment, for example. We call those evaluation tools or evaluative tools. And then we've also got measures that are really designed to help you as a clinician decide whether your patient is ready for discharge to an independent home management program, for example. There is no shortage of patient-reported outcomes in the pain field alone. If I was to guess, I wouldn't be exaggerating to say hundreds, probably not even into the thousands. There are a lot of different patient-reported outcomes out there. You can measure everything. You can measure spousal responses to pain. You can measure cognitions and emotions and behaviors and all these sorts of things. However, consistent survey evidence tells us that far and away the most common patient-reported outcome used is a 0 to 10 numeric rating scale. And that's when we can get people to actually use outcomes. Most commonly, people don't use anything at all other than asking the patient. So, they're hard. Now, as we've moved towards trying to measure personal subjective experiences, a whole field called psychometrics has opened up. And that's introduced all sorts of weird concepts and constructs. So, for example, I mentioned earlier that we're unable to directly observe most psychological phenomena. We're going to include pain in there for the time being. What that means, though, is that pain, well-being, quality of life are now termed latent constructs. In other words, we can't directly observe them, but we can predict them by virtue of how you respond to things. Maybe I could predict how much pain you were in by maybe how much you wince and you splint yourself and you guard, and how much pain you say you have when I ask you on a scale, and how much you yell when I poke you. I could guess, I can infer how much pain you've got, but I can't, of course, directly observe your pain. So we've got concepts like that, the latent construct. We've got shared variance. We've got random error, which is always a really interesting term. People who are familiar with measurement theory will recognize that in a field called classical test theory, there's always an error term on the end of any evaluation that we do. And this is that sort of random error that really is completely unexplainable when it comes to, for example, reliability measures. Random error is sort of what goes beyond measurement error. And it could be, who knows, the earth tilted on its axis a little bit, and now, the patient's pen marked a 4 instead of a 3. We can't account for that sort of random error, but that does mean that it's very difficult to understand a lot of measurement science. Frankly, it's hard enough for people like me who live in this world to understand. I'm not sure how clinicians are meant to understand that in combination with all the other important aspects that go into being a good clinician. And then if we want to make it even harder, we can move from classical test theory, which most of you will be familiar with, concepts of reliability and validity and that sort of thing are often built around classical test theory, into what are called newer approaches to measurement analysis, which include rash analysis and item response theory. And that just adds a whole other layer of complexity on top of this. So again, the point is here, trying to understand and choose a good quality patient-reported outcome, it's kind of hard. So let me give you some examples of just sort of how maybe more challenging this field is than we perhaps might give credit for. I'll pose this question. What is the clinically important difference of a numeric pain rating scale? 1 point, 2 points, 2 points or 30% of the baseline? That's often cited. 3 points maybe? Maybe it's just 20% of the scale. In this case, 0 to 10 would be 2 points. Most of you will probably be familiar, and some of you are likely thinking, it's 2 points, or it's 2 points or 30% of baseline. Those are two of the more common ones these days. But what if I told you that it's actually not consistent? And this is what I mean, where it starts to get a bit more challenging. Here's a paper that we actually just had published about 2 weeks ago, in fact, in the Journal of Hand Therapy. They did a special issue on pain and invited us to provide an editorial. Well, in that, what I did is I showed how if we take a subscale of the brief pain inventory, which includes 4 different pain intensity measures, then that allows us to do this rash analysis kind of approach here. And without getting too far into the weeds on what rash analysis is, one of the things it allows us to do is take an ordinal level scale, 0, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and locate each of those numbers along, you can imagine, a ruler, so an interval level scale. And so it positions them along sort of specific points on that interval level ruler, such that the space between 0 and 1 is in fact conceptually the same as the space between, say, 5 and 6. Now, when we do that, what we find is something that looks like this, that the responsiveness of the tool, the information gained between successive steps, is not consistent across the whole breadth of the scale. That at the ends of the scale, if we take a look here, you see this S-shaped information curve, at the ends of the scale here between 0 and 1 and up here between 9 and 10, the amount of information we gain on an interval level is quite large. Whereas in the mid parts of the scale, where the curve here is far more flat, the amount of information we change when we go from a 4 and a 5, the amount of information we gain is quite low. And that can be shown over here on the right, where if I take a look out here, I just plotted the information gained on a step from, say, 0 to 1 or from 9 to 10 is quite large. In fact, it's probably clinically important. So a 1-point change is probably clinically important. On the other hand, the amount of information we gain when we move from a 3 to a 4, or a 4 to a 5, or a 5 to a 6, not really that important. So here, a 1-point change may not be important. A 2-point change may not be important. You might need 3 points to change before you can be confident that clinically important change has occurred. The point here is that it's probably not good enough to simply measure or to memorize a single cut score for clinically important difference. That it probably varies across the breadth of the scale and is more important, a small bit of change is more important at the ends of a scale than it is in the middle. I know, great, thanks Dave, now you're making this even more challenging. You just told us that people aren't using outcomes well enough, and now I've decided to add an extra layer of complexity. But this happens often enough that really we can't ignore it. In fact, every rash analysis I've done, and believe me, I've done a lot, shows pretty well the same thing. That no matter the scale we use, the information you gain from small shifts at the ends of a scale is bigger, it's more important than the information you gain from small shifts in the middle. Clinically, that makes sense too. You can imagine, a shift from 0 to 1 conceptually is really important, right? You're going from nothing to something. Same thing on the other end, a shift from 10 to 9 also should be conceptually important. You've gone from the maximum possible of something to something less than the maximum. So those seem like important, conceptually important shifts. We don't often think about it that way when we try to memorize a single clinically important difference value. So there's an example of how we probably need a little bit of help to interpret these scales from time to time. Here's another example. Some of you might be familiar with these right off the bat. What I've got here on the left is a recently derived clinical prediction rule from Kerry Ritchie, and who was working with Michelle Sterling at the University of Queensland. The intention here to create a tool that would help you identify the person at risk of developing chronic pain following whiplash-associated disorder. So in this case, it's within 3 weeks of a WAD. You can bring your patient in. You start by giving them the Neck Disability Index. If they happen to score less than or equal to 32 out of 100, this is rated out of 100, so 16 out of 50 for those who are familiar with the NDI, that earns them already sort of membership to this lower risk group. If they also happen to be 35 years old or lower, then they get membership in the full recovery prediction group. On the other hand, if your initial administration of the NDI has them score 40 or greater, 20 out of 50 or more, and the poor folk happen to be 35 or over, which is quite young, then you also get to ask them to complete another scale, which is the hyperarousal subscale of the post-traumatic stress disorder scale, or PTSD diagnostic scale. And if on that one subscale, the hyperarousal subscale, they score 6 or higher, well, now they're in the high risk, likely to not recover group. It's not that simple. Of course, if they don't happen to follow either one of these nice trajectories, then we don't know what's happening with them. They're in the neither full or non-recovery group predicting. What about over here on the right? We've got the Keel Startback tool, another tool that some of you may well be familiar with. Nice, simple little tool. What we love about these is that for each of these questions, all the patient has to say is whether they agree or disagree with the statement. You can see there are a number of statements here. This is for low back pain, same deal, trying to predict those who are unlikely to recover. Over here, the very bottom one, and the 9th one, we've got a question around overall, how bothersome has the experience been. You can sum your total score up. Keep in mind that not at all, slightly, and moderately for bothersome are all scored 0. And very much or extremely are both scored a 1. Need to remember. Then you can go down to our handy little prediction algorithm down here on the right. And again, we can sum the total score first of all. If it's 3 or less, this patient is likely in the clear. If it's 4 or greater, then go back and rescore sub-questions number 5 through 9. If those are 3 or less, they're in the medium risk group. If those are 4 or more, they're in the high risk group. You got it? Lots to remember. Let me give you one more example, in case I haven't convinced you well enough yet. One of our new tools, the Traumatic Injuries Distress Scale. This is one we published a couple of years ago in JOSPT. It's a 12-item prognostic screening tool. You ask the patient to indicate basically how frequently they experience any one of the 12 different symptoms there. The item or the tool itself is meant to provide different subscales, and it's meant to tell you not only the magnitude that somebody's at risk of developing a chronic problem following any acute trauma. It doesn't have to be whiplash or low back pain. It could be anything, any MSK trauma. And what we've got here, I can show you, we've got a correlation with the total score of the TIDs with, for example, percent interference on a brief pain inventory or an NDI. Yeah, decent correlation, R of 0.47. Not terrible, not bad. Tells us that interference is probably a function of more than just traumatic distress. We're okay with that. We got some cut scores we found here. If you score less than 1.5 out of 24, you're in the rapid recovery group. If you score over 7.5 out of 24, you're in the slow recovery group. We were about 78% accurate with just this tool. Cool. Seems fine. Now it's possible that you may be able to remember these two numbers, these cut scores, 1.5 and 7.5. Depends on how many tools you use on a routine day and how much memory capacity you have. But of course, it's never that simple. That's the point of what I'm trying to describe here. So if I was to show you a scatter plot of our TID scores, we've got about 200 and something TID scores here, with percent interference, again, on our NDI, our brief pain inventory. Here's our correlation of 0.47. Not bad. Seems a little bit messy. We got a few people sort of way up here that are well off the line, dragging our correlation down. But if I go and separate that by people who have either had trauma affecting their periphery, so their upper or lower extremities, versus people who have had trauma affecting the axial spinal region, the neck or the lower back, the correlations are quite a bit different. Now the story gets a little bit messier. And lo and behold, we end up finding different cut scores as well for spinal and peripheral conditions. And we're actually more accurate at predicting outcomes in the spinal conditions than we are the peripheral ones. And as it turns out, we are not very good at predicting outcomes for people under 44 years old, also very young, but we're quite good, in fact over 90% accurate, for predicting outcomes with people who are over 44 years old. And that's a lot to remember. And this is part of the challenge here. And perhaps when I sit back, I think to myself, well, geez, Dave, it's no wonder people aren't using patient-reported outcomes all that much. Because I'm sitting here telling you there are a lot of caveats, there are a lot of different ways to understand how you interpret these things. So, technology hopefully to the rescue here, I think. By now, I hope I've convinced you that patient-reported outcomes are important, that what the patient says is the nearest thing we have to a gold standard for understanding their experiences. But I've also probably just convinced you that interpreting them is likely a lot more difficult than you maybe would have learned in your training programs. The great thing, however, is that these wonderful little mobile technologies that we carry around in our pockets are able to remember all of this without us taking up any valuable mind space. So a dirty little sort of secret here of measurement scientists, and I'm going to let you in on this, is that so far, when we provide something like a clinically important difference, we might only provide one, at most two, cut scores, because truth be told, we're not really convinced clinicians can remember more than that. Or at least that they want to remember that more than that. Bit of a mean thing to say, isn't it? Frankly, I can't remember more than that either. But that's not that saying that there's only a single cut score. So if we set a cut score, let's say, for example, of a clinically important difference on a numeric rating scale was 2 points out of 10, does that mean 1 point out of 10 is meaningless? Well, no, I've already shown to you that 1 point out of 10, depending on where they started, could be meaningful. Does it mean that when I show you my TIDS cut scores, that 1 and 2 are a critical distinction? How do I interpret the difference in risk between somebody who scores 0 and somebody who scores 10? I don't know that because I haven't given you that information. I know that. I've actually got it. I can create nice little receiver operating characteristic curves, and it shows me for every possible cut score what the likelihood that my patient's going to be at risk of developing chronic pain is. But we don't publish that. We don't publish that because we don't, until now, believe that it's really been something that clinicians could interpret. I'm being quite honest. I'll give you a little peek behind the curtain here. So as a result, you get maybe 1 or 2 cut scores for screening. You get a single universal change score for clinically important difference. But consistently, we're now seeing that the use of a single score for interpretation that's equally applicable across all scale scores or all clinical populations, what about my age issue here, probably is leading to a few misinformed practice decisions. The great thing is that we can get away now from these rules of thumb. We can program mobile technologies to interpret these breadth of scores and give us very concrete information that is probably more accurate than what we've been able to get so far. The nice thing here is that now this rich information can be accessed literally in your pocket at point of care. So when I sort of put on my futurist hat and I look into the future, 5-10 years from now, what I'm seeing is that the emergence of mobile technologies are going to lead to more informed treatment decisions. That patient responses on a patient-reported outcome can now be interpreted within appropriate context of the patient themselves, their age, sex, the region of their body that's affected, maybe their household income, whether they're involved in litigation or not, culture, ethnicity, literacy, and I mean, who knows, a whole host of other things, genetics, life adversity, environment, diet, you name it. There are probably a number of things that influence the way we should be interpreting things like cut scores. But again, we don't dive into that. We haven't given you that because to date, it's just been deemed too complex to be clinically relevant. Now, as people start to hear me talk about this tech thing, and maybe, I don't know, maybe it's already come up with the speakers prior to me, depending on your vintage, you start to sort of have visions of, how in your mind of, the evil artificial intelligence that's going to try and destroy all humans, or maybe, I don't know what your vintage you are, maybe it's Terminator, maybe it's Ultron, whatever. Hollywood's got a long history of artificial intelligence is trying to kill humans. So could it be that the HAL 9000s of the world are going to take over our jobs? Do we still need us? Well, maybe. I suppose it's possible. I mean, if technology is allowed to just sort of flourish unchecked, then yeah, maybe. But remember back to my initial slide, I talked about augmented rehabilitation. What about augmented physiotherapists? That's kind of what we're getting at here. Is what if I have a device that could give me far richer information than what I can just simply memorize in my head, and that helps me make more informed clinical decisions. So rather than HAL 9000 coming and taking all of our jobs, I prefer to think of a future more like one of my favorite superheroes, Iron Man, where he's got his own artificial intelligence, Jarvis, and the two of them work together such that they both accomplish more than either one could on their own. That's the future of rehab that I'm imagining. So what I want to do here, I'm going to take a quick pause, I'm going to flip to another screen, and I want to show you an example of what we've been trying to do with this new app that Mike's company has been working on to hopefully bring patient-reported outcomes and high-level interpretation to the masses. Be right back. All right, so what we've got here is a mock-up of a new outcome measures or patient-reported outcomes app that Mike's company, PhysioU, has been working on and working on with me to try and bring this sort of area of knowledge and understanding to clinicians right at the bedside, right at the point of care. The way that this app is currently set up is to first allow you to choose the body region that you're working on. And what I'm going to do here is I'm just going to choose head and neck for the time being. And immediately I get questions around demographics of the patient themselves. So age, what I'm going to do here is I'm going to imagine I'm a younger man than I am, and I'll put 32 years old. I'm going to call myself male, and let's say I've had this pain for less than 3 months. So acute pain onset, or at least subacute. Now, what the app is then going to do is present me with a number of different tools that I could choose and have my patient fill them out, or I can just go and enter the number if I already know what they've scored, say, on a paper version of the form. Right now, so far, we've got the Neck Disability Index and my own shortened version of the NDI that I published a couple of years ago. We're quite happy that we just recently got permission to do so through the license holder of the NDI, which is fantastic, and we're continuing to get more of these licenses and are going to build these in. The pain catastrophizing scale is one that we're working on getting the license for, and the Brief Illness Perceptions Questionnaire is one of my favorite tools. It's open access, it's widely available. But I want to show you, I'm going to start with the Neck Disability Index. Some of you will be familiar with the NDI. It takes you now to a screen, and keep in mind this is going to show up on your smartphone. In this case, it gives the information to the patient about what the tool is for. As I said, if I already had the patient fill out the form, maybe in a paper version, and I already knew that they scored 12 out of 50, I can just enter it right here. But let's imagine I haven't done that. The way the app is designed is that we can actually have the patient go through and they can choose each of their responses. I'm just going to choose some real quick here. For each of the 10 different items on the Neck Disability Index. I actually love the way that it scrolls up to the next item. Isn't that cool? Once I've done that, then I can go and hit Submit Questionnaire. And here's the great thing. What Mike's programmer has done is not only giving you the sum score, which is great, the disability rating, which is basically just the same score out of 100, percentage-wise. It has used, remember that Carey Ritchie predictive algorithm for whiplash-associated disorder? I've just told it I've got acute neck pain. Now, it doesn't know that I have traumatic neck pain or not, but you know, as a clinician, and it'll just tell you, it doesn't need to know, but it'll say, if you want to know, this person is predicted to have a full recovery or mild disability. Why? Because I told it I was 32 years old, remember that magic cut age of 35, and I've only scored 6 on the NDI, less than 16. So already now, the app itself is remembering that prognostic tool for me. I don't need to keep that one in my mind. It's given me full recovery expected. And what it's also done, get ready for this, remember when I told you that rash analysis goes and takes those ordinal level scores and plots them along a interval ruler, and then it tells you how much change is needed in between for real live change, and that probably differs if you're at the poles or if you're starting in the middle. Well, this app has gone and taken my ordinal level score, it's done the rash-based transformation. From there, it's subtracted what we think about as a clinically important difference, which is generally about 5 points on the NDI, 5 to 10, depending on who you ask. And then it's retranslated that back into the ordinal level score, and it's told me that my target score for meaningful change is 1. Very cool. Now, let me just show you a different example here. If I go back to the diagram, let's choose the head again. Let's go back to the NDI. And this time I'm going to make things a little bit worse. So I'm going to say that I'm good in a few things here. Reading I'm not very good in. Let's say I have no headaches. I'm able to concentrate, but my work is struggling. I'm fine driving. I'm okay sleeping. And I'm having a little bit of a hard time recreation-wise. Now I submit questionnaire. Again, now I've scored 13. Okay, so I'm still below that magic 16-point cut score on that prognostic tool. My disability rating, which translates to mild disability. I've got my prognosis again down here, full recovery, because again, I've told it I'm less than 32 and I've just scored a 13. But now what it's also done, and this is what's beautiful, this is the way we should be using patient-reported outcomes, is not just interpreting the overall score, but looking at the individual item responses. That opens up so much communication with your patient, and I'm not sure how many people do that. If you don't, I encourage you to start doing so. This app does that for you. It's looked at the ones that I'm scoring a little bit higher on, and it suggested you may want to follow up on this person's pain intensity, their interference with reading, and their interference with work. Again, it's gone and it's done the rash transformation. It's told me what I need for a meaningful change score, showing me a score of 8. So you don't need to remember any of this. The nice thing about these tools is that I don't need to take up my valuable mind space. It's all right here. This is what I see as the future of augmented rehabilitation. I just need to flip screens again. Okay, and here we are back at my initial screen. So that was just a quick demo. For those of you who are interested, I have programmed some other apps in the past. None of them are nearly as pretty as this one is, but you can get them all from my lab's website if you like. And here's the information on that. So my lab's website here at the bottom is pearlresearch.com. There's a number of free, some of them are applications, some of them are printable forms if you want them. I make exactly $0 off of them. You're welcome to put them out. They're all, as I say, they were the result of publicly funded work, so I figure I might as well make them available. If you have any questions, by all means, here's my email address. You can follow me on Twitter. I do post, I do actually have a YouTube channel. It's a wonderful cure for insomnia if you should happen to be suffering. But if you want to see some of the different measurement tools that I've worked with, that I've created, go ahead, check out the YouTube channel. I think I get about 1/100th of a penny every time you watch a video. So anyway, thanks for listening, and on to the next speaker.